Hello, everyone. Welcome to CureAccelerator Live for Pediatric Rare Diseases. I'm Barbara Goodman, and I, along with Claire Thibodeau, are thrilled to present our third annual CureAccelerator Live with the Global Genes and Orphan Disease Center at the University of Pennsylvania. Cures Within Reach is leveraging the speed, safety, and cost effectiveness of medical repurposing research, whether these projects serve commercial or philanthropic use. As the COVID-19 pandemic showed all of us, it's shined a spotlight on what we've known at Cures Within Reach for over a decade. And that's the fastest way to reach therapeutic impact of patients is using already approved therapies and randomized controlled trials. The rare disease community knows this very, very well, since every day, not just during a pandemic, they live in crisis mode. Cures Within Reach for over a decade has funded nearly 100 different projects in a wide variety of diseases. Our $7 million in funding leverages follow-on funding of our researchers and of the trials. In fact, our $7 million has catalyzed more than $67 million raised by our researchers. We are disease agnostic, we're geography agnostic, and we're institution agnostic. And in 2021, not only are we featuring and highlighting pediatrics today with this event, but we're also going to be selecting clinical repurposing trials to impact veterans issues such as depression, PTSD, and brain injury. We're selecting later this year and have an open call for proposals right now, an opportunity to make an impact in health disparities. We have an open call for proposals for minority-led, underserved, racial minority researchers across the United States. And finally, our second year of making an impact by building capacity for clinical trial research in low and low middle income countries within the developing world. We currently have 33 ongoing projects at 28 different institutions in 21 diseases. And we're really proud of the work that we have with our partner research institutions and clinicians. But we're all here today to talk about rare diseases. 42% of our ongoing projects are in the rare disease space, everything from blood cancer and sight impairment diseases to immune disorders and many other areas. And they're also in many countries as well, across the United States, in Tennessee, Washington, Michigan, California, and Pennsylvania. But we also have projects in the United Kingdom and in Vietnam. Our first project in Vietnam was signed earlier this year. We're really excited about these, both in adults and in pediatrics. And it should be noted that 5 of these 33 projects were selected at previous CureAccelerator Live for Rare Diseases events in either 2019 or in 2020 at this event. In addition, we're looking at pediatrics today. 24% of our ongoing projects are in the pediatric space in Colombia, Vietnam, as well as the United States. Illinois, Pennsylvania, and Tennessee are working on projects in cerebral palsy, in dengue fever, as well as in cancer, various pediatric cancers and immune disorders as well. Tonight, we really want to thank our philanthropic partner, the Charles H. Hood Foundation. The Charles H. Hood Foundation is focused on improving the health and quality of life of children since 1942. We're thrilled to have many of the Hood trustees and Hood Foundation staff join us today. And it's been a wonderful, truly collaborative partners to reach us, to reach the decisions that we're going to be making in the next 24 hours. So thank you very much for your partnership. We also want to thank all of our industry members, as well as our healthcare community members and philanthropic community across all of our disease areas in rare diseases, as well as our pediatric community members. We're very, very grateful for your ongoing support. And now it's time for the program. I'm going to turn it over to Claire Thibodeau, who is going to moderate the rest of the event for us tonight.
Thanks, Barbara, and thanks to everybody who's joining us here tonight. For those of you who don't know much about CureAccelerator Live, you're in for a treat. And I'll have to say, you've come to the right place if you want to make an impact in pediatric rare disease. And that's because every person who attends tonight gets a vote to help us select the winning project. So what we'll do tonight is we will look at some pre-recorded pitches that our finalists have made, followed by live Q&A with our expert panel, and then voting will open. You'll also be able to chat one-on-one with our finalists by using the posters that they've created. You'll find those in the main event section. If you go to the poster tabs on the side of the screen, you can access their posters and hit the discussion button that way to chat with them. But don't take too much time chatting because voting closes at about 5:45, so you want to make sure you cast your vote before then. And then tomorrow morning at the start of day 2 of the Rare Drug Development Symposium, we will announce the winner. As I mentioned, we have an expert panel who's going to help us with questions and answers, and we have representatives from all different stakeholder groups. We have with us, first of all, Amit Acharya from Advocate Aurora Health, representing clinical medicine. From Horizon Therapeutics, we have Chris Hudson, who will be bringing the industry perspective to the questions. Christian Rubio from our very own Global Genes will be bringing the patient voice and making sure patient ideas and thoughts and concerns are represented. And last but not least, we have Robert Segi, who not only is a professor at Tufts, but is also a senior scientific advisor for our philanthropic partner, the Hood Foundation. So as I said, each one of you is going to play a very important role in helping to select the winner. So as you listen to the pitches and the questions and answers, please take in consideration our 5 voting criteria: patient impact, probability of success, speed to patient, assessment of research team, and overall presentation. We'll be sharing these considerations with you again after the videos and when we give you voting instructions, but kind of keep these in the back of your mind as we're going through each presentation. And of course, it would not be CureAccelerator Live without fantastic finalists. And this year, I kind of feel like we've outdone ourselves a little bit this year. We have finalists from the US and one from Chile. We are very excited to have them joining us. They all have impactful projects that really have the potential to create impact for rare disease patients and their caregivers. You know, I am not kidding when I say I think it's going to be a tough choice for all of the attendees who are voting here today. But you don't want to hear about these projects from me. You want to hear about them from the finalists themselves. So let's get started with our first presentation. Nancy Gordon from MD Anderson talking about recurrent and metastatic osteosarcoma.
Hello, my name is Nancy Gordon. I'm an associate professor in the Department of Pediatric Research at the University of Texas MD Anderson Cancer Center Children's Cancer Hospital. So I will thank you for the opportunity to present my work. And I would like to start by emphasizing that one of the major concerns of this lethal disease, osteosarcoma, is that there are no good treatments for recurrent metastatic disease. So here we offer an opportunity for an alternative treatment that might improve the survival of these patients. Osteosarcoma is the most common primary malignant bone tumor in children. It is still a very rare tumor with only few cases diagnosed in a year in the U.S. And as you can see from those, 400 affect populations less than 20 years of age. However, the rarity of the tumor, the complexity, the big heterogeneity of these tumors makes it a very difficult disease to study. And so osteosarcoma constitutes about 6% of all childhood cancers and about 35% of all bone cancers. However, I'd like to emphasize that only 400 new cases appear per year in the AYA population, but for those 400, about 20% of those, which is about 80 cases, present with metastasis of diagnosis. And these really constitute a poor prognostic sign, as there's a treatment failure on these patients of about 85%. In addition, 50% of those 400 new cases relapse, and 80% of the relapses occur in the lung. And this is really the major cause of death of these patients. So how do we treat the patients now? We use chemotherapy, then we take the patient to surgery for limb salvage procedure, and then give additional chemotherapy. It usually takes care of the primary tumor in most of the cases. However, the patients are left with significant side effects due to chemotherapy. And one of the major ones is cardiotoxicity and nephrotoxicity. In addition, patients come back with relapse, and in 80% of the cases, relapses occur in the lung. And there are really no good therapies for relapsed recurrent disease. And in addition, treatment is very expensive. We have therapies to offer to these patients as an alternative, but none of them have shown significant benefits. I would like to point to you the highlighted regimen there, gemcitabine and docetaxel. And the reason is because gemcitabine and docetaxel are the National Comprehensive Cancer Network recommendation for patients with second-line therapy with patients with osteosarcoma. However, it has shown, as I mentioned, very limited efficacy. We previously demonstrated in our preclinical studies using a murine osteosarcoma mouse model that given aerosolized chemotherapy with gemcitabine has significant therapeutic efficacy. As you can see, it decreases the number of pulmonary metastases. However, we also show that gemcitabine induces a process that is called autophagy that conveys resistance to chemotherapy. So we thought that if we give an agent able to inhibit autophagy, we might enhance chemotherapy efficacy. So indeed, we choose hydroxychloroquine, which is an already approved, FDA-approved drug for the treatment of other diseases, and adding this hydroxychloroquine with gemcitabine, we showed that there was increased significant benefit in treating these osteosarcomas. So we hypothesized that adding hydroxychloroquine to the already standard gemcitabine and docetaxel regimen might enhance the survival of these patients and will increase the 4-month disease control rate, and in addition, will not add toxicity to the already established regimen. So based on this, we designed a phase 1-2 trial of gemcitabine and docetaxel in combination with hydroxychloroquine for patients with recurrent metastatic osteosarcoma. So this is the design of the study, but what I would like to point out is that we're currently enrolling in phase 2 dose expansion. We're planning to enroll a total of 25 patients during this phase 2, but what's most important for us is that we really need to do biopsies in these patients pre-treatment and on-treatment, as these biopsies will help us better understand why certain patients may or may not benefit from the treatment, and in addition, identify potential biomarkers of response that could be used to select patients for these or any other clinical trials. We're planning to complete these in 2 additional years. So we're really asking here for support on our patient biopsies. This is very important for us to really understand the benefits of adding this third drug. And we're very committed to the completion of the study, and indeed the institution had supported initially biopsies in those patients, but because of COVID, these funds were cut. So the funds that Cure Within Reach offers are critical to inform clinicians of a potential effective therapy for patients with recurrent relapsed osteosarcoma that will learn from these biopsies. So the team is conformed from this study is a very strong team that has 3 physicians, Dr. Livingston, which is responsible for the design of the study with a strong background in osteosarcoma, Dr. Kleneman and I are the pioneers of the preclinical studies that led to the design of these clinical phase 1 trials. So the overall impact, we believe that there are very limited treatment options for these patients with relapsed recurrent disease in the lung. Using these 3 drugs that are already approved by the FDA and are commercially available will allow us to get these treatments readily available to all patients with recurrent metastatic disease in the short to medium term. So with this, I will end, and I will thank you again for the opportunity to present my work.
Thanks, Nancy. You know, what I really like about your project is that it shows how repurposing can be an avenue for patients who really may not have a lot of other options. So thank you for that. So now we'll begin the Q&A with the expert panel. Chris Hudson from Horizon Therapeutics. Do you want to kick us off?
Yes, thank you. Thank you for the very nice and powerful presentation, Dr. Gordon. Can you please expand on the types of biopsies that will be sampled? For example, would the focus be on the primary osteosarcoma tumor versus lung or other tissue metastases? And then also from those samples, what types of biomarkers would you be focused on that specifically might be impacted differentially following treatment with hydroxychloroquine?
Absolutely. Thank you for the question and the opportunity to present and do all the work to you guys. So we will be doing biopsies from recurrent disease. So if you heard on the presentation, usually the main cause of death are pulmonary metastases. So this tumor almost always metastasizes to the lungs. Eventually, it could also metastasize to another bone, but most of the biopsies we expect to be from the lungs. And regarding these will be pre-treatment and on-treatment biopsies. Regarding the biomarkers, so if you also heard of the presentation, really what we're trying to target here is autophagy, and these is using hydroxychloroquine. So we have found that it's very difficult to define whether inhibiting autophagy will lead to either enhanced sensitivity or decreased sensitivity. So the biomarkers that we have found is like, first we're going to test whether the treatment induces autophagy and whether autophagy is inhibited, and we have identified potentially a heat shock protein, a small heat shock protein, HSP27, that we believe can define whether inhibition of autophagy will lead to survival or death. So we also have a couple of markers that have been identified by another colleague of us working in autophagy, who had identified ALDH or HLP-T as additional biomarkers that can define whether the patients are responding or not responding to the addition of hydroxychloroquine.
Great, thank you.
Thank you. Amit Acharya from Advocate Aurora Health. Do you have a question for Nancy?
Dr. Gordon, thank you so much for your presentation today. Obviously, as we all know, kind of the risk versus the benefit is an important, central function of, assessing the drugs, or kind of when we are also repurposing. Clearly, hydroxychloroquine is kind of, very well recognized for treatment of malaria, but here in this instance, what consideration has been given as you're trying to kind of, repurpose that for osteosarcoma? Are there any major side effects that the patients or the research subjects, need to kind of, think through, and what is the team kind of thought about it? If you can elaborate a little bit from a patient safety perspective and the risk versus benefit perspective, that'd be really helpful. Thank you.
Sure. So absolutely. So we actually have, we don't really expect major side effects from hydroxychloroquine. In fact, one of the main concerns of hydroxychloroquine has to be toxicity, mostly with retinal detachment, but that's really, really, really rare. But before treatment, we actually have ophthalmologists assess our patients before anything, just to make sure that they're not at risk for these to happen. And everything, we're in close contact with the patients. But other than that, really, there hasn't been anything really big, major toxicity reported. So it seems to be very safe. And in fact, if you saw the presentation, we have already enrolled 17 patients. Yes, the 2 initial doses are low, but then now we already reach the dose that we call the maximum tolerated dose, and we have not seen any kind of toxicities related to hydroxychloroquine. So it's overall pretty safe.
Thank you.
So let's turn now to Bob Segi. Bob, do you have a question for Nancy?
Sure. First of all, Nancy, that was a great presentation. And you really set out for us the need for a better treatment for this terrible condition of osteosarcoma. My question focuses on the probability of success for your project. When I looked at your poster on Figure 2, you had your preliminary studies. The change didn't seem to be very dramatic. Can you explain why you're optimistic about the success of this compound?
So I only actually showed, within, it was a very limited, space that I had to actually show it in the poster. But indeed, there is, it doesn't seem to be a whole lot, but if you saw, on its own, when we gave aerosolized gemcitabine in this case, we have a pretty good response. And so adding additional, even, like 15 or 20 more % additional sensitivity is a big deal, and it's very significant when it comes to these type of disease and therapies. This disease has been very reluctant to respond to a lot of different therapies. And usually, if it does respond, the disease comes back in the lungs. So seeing just at least 15 to 20% increase in response, it's really significant. So I hope that answered your question. So, and, additionally, having all the drugs already being approved, and particularly hydroxychloroquine, will make it very easy to be implemented in patients. And so, that's why we're really looking for biomarkers of response, because that will tell us for sure. And, these trials are very well controlled. So we're assessing patients that have been enrolled every 4 months. So we will know at certain point whether, the likelihood of these trials to be successful is, yes or no. And so we can stop it at a certain point. So, yeah.
Great. Well, thank you, Nancy, and thank you to the expert panelists for these questions. We will be moving on now to our second finalist, Joseph Rauer out of the University of Utah. So let's bring up Joseph's video.
Thank you to Cures Within Reach and the reviewers for the opportunity to present our work on repurposing the antiviral valganciclovir to treat congenital cytomegalovirus-induced hearing loss. Congenital cytomegalovirus, or CCMV, is a primary infectious cause of sensorineural hearing loss, which is in turn responsible for substantial speech and language impairments in children. To date, there are no approved therapies for treating CCMV, leaving clinicians to use antivirals such as valganciclovir off-label. While there is evidence supporting the utility of valganciclovir for this application, its use is hindered by extensive interpatient variability in the relationship between dose and response, and the narrow range in therapeutic exposures that are both safe and effective. You can think of this as an individual's preference for putting salt on a steak. In one case, when not enough is added, the steak is bland. For valganciclovir, if not adequately dosed, it is ineffective. As exemplified by patient 1, who received a standard dose of valganciclovir, but progressed to deafness, had substantial impairments in their speech and language development, and eventually required a cochlear implant. When too much salt is added, even though the steak might taste okay, the diner risks skyrocketing blood pressure. When a child is exposed to too much valganciclovir, the drug yields stable hearing outcomes, but it increases the risk of adverse effects of the drug, such as neutropenia, as exemplified by patient 3. When the steak is salted just right, the steak is delicious without the added risk of hypertension. This is like patient 2, who underwent drug monitoring studies to individually tailor her valganciclovir dose, resulting in safe and effective therapy, stable hearing outcomes, and normal speech, language, and social development. Identifying the appropriate dose of valganciclovir is necessary to successfully repurpose valganciclovir for use in CCMV-induced hearing loss. CCMV occurs in approximately 20,000 infants annually, a prevalence of about 0.5% in the US. Of these children, over 20% will progress to hearing loss, 7,000 will exhibit some form of impairment or disability related to the infection, and approximately 400 will die. The unfortunate truth is that these sequelae will persist as the child ages, decreasing their ability to communicate and socialize with their peers, and diminishing their quality of life over the entire lifespan. Not only does CCMV significantly impact the child's well-being, it places significant financial strain on the patient's family and the healthcare system as a whole. CCMV and the associated disabilities cost the US healthcare system approximately $4 billion annually, more than the GDP of many small countries. At the individual level, the cost of immediate postnatal care for a CCMV-infected newborn costs about 4-fold more than uninfected newborns. While over the course of a child's lifetime, CCMV is estimated to cost $1.3 million. This is in stark contrast to the average retail cost of 6 months of valganciclovir of just under $3,500, which is potentially even cheaper when purchased through insurance or with medication coupons. Thus, effective valganciclovir therapy, for example in the case of patient 2, can yield a nearly 400-fold savings over the life of the patient. This project really resulted from the numerous examples I've had in my career of the critical role that drug exposure plays in linking dose and response. From graduate work that used drug exposures to show a drug's utility in preventing HIV, to finding patient-specific factors defining the necessary dose of immunosuppressants following heart transplant in children, to the stories of the 3 CCMV-infected infants I shared earlier, whose outcomes really turned on the use of drug monitoring to achieve the appropriate valganciclovir dose. My research has focused on using pharmacology to improve patient outcomes. Specifically, my experiences speak to the need to understand the complex relationships between dose, exposure, and response, which are even more complex in children and for drugs that exhibit narrow therapeutic windows, such as valganciclovir. Defining this relationship for valganciclovir will allow us to repurpose the current off-label use of the drug into something that is evidence-based and tailored to the individual child, which we anticipate will greatly increase the efficacy and safety of the drug. This $50,000 CureAccelerator grant will enable the analysis of dried blood spots collected from Valier to determine drug concentrations and viral titers using well-established and validated methods. While Valier received substantial NIH funding, those funds did not cover these analyses, which were requested by the FDA as part of the IND process. These data are really critical to defining the dose-exposure response relationship that we will use to individually tailor valganciclovir therapy, which we expect to benefit patient care sometime in mid-2023. I am fortunate to be joined in this research project by 2 internationally renowned experts in cytomegalovirus infection, Dr. Albert Park and Dr. Mark Schleiss. Dr. Park has particular expertise in cytomegalovirus-induced pediatric hearing loss, while Dr. Schleiss specializes in clinical virology with over 100 CMV-related publications. My research focuses on pediatric personalized medicine, using pharmacologic tools to tailor dosing regimens to individual children. Combined, we make a unique, formidable, and complementary team for treating CCMV-induced hearing loss. In summary, being able to share more stories like patient 2, who maintained her hearing due to valganciclovir dosing that was optimized for her using drug monitoring, relies upon knowing the dose exposure response relationship in CCMV infected children. Successfully repurposing valganciclovir to treat CCMV could yield an enormous 400-fold savings over the child's lifetime. Combining these results with the findings of the VALIR trial will have an immediate impact on the off-label use of valganciclovir to the great benefit of the patients. I think this project forms a perfect union between Cures Within Reach's mission to drive more treatments to more patients more quickly through the use of personalized medicine, which seeks to use the right dose in the right patient at the right time. Thank you.
I'm sorry, I was on mute. It happens once every session. Thank you for that, Joseph. And what I'd like to do now is, since Christian Rubio from Global Genes did not get to ask a question yet, Christian, take it away with your question.
Sure thing, and thank you so much. These are great presentations and really enjoyed this one too. I think I'm going to lead with one important question, I think, as I understood the explanation, both of the condition and what you're seeking to do. CMV really is complicated and it seems to be highly individual. In your proposal, you're looking at potentially researching with an age range of very, very young, a 1-year-old through 12 years old. With a precision approach like this, how do you plan to control or bring consistency to all the variability that each presentation could bring with it?
Yeah, so I think we're looking at 1 to 12 months, not years. So we are looking at just the infants. But yes, that's part of the beauty of population pharmacokinetics, where you take all these patient-specific factors and build them into one model to really define how dose and exposure are linked within an individual, but also within the entire population.
Thank you very much.
So now I'm going to ask Bob again. Do you want to chime in with your thoughts for Joseph?
Sure. Joseph, first of all, congratulations. This is a really big problem. And if you have a medication like ganciclovir that works, it would be really a big benefit. I had like a pretty specific question. In your video, you had 2 patients, I think patient 1 and patient 3, who each got the same dose of medication, 16 milligrams per kilogram divided twice a day. And they had really different responses and the curves looked different and they had different symptoms and stuff. This seems to me like it might be a barrier to adoption, and overcoming that barrier would speed patient access. How do you anticipate your results on pharmacokinetics being used in clinical care, and will patients not be monitored for drug levels somehow? Or where do you see this going?
Yeah, so I would definitely advocate for therapeutic drug monitoring. I think that's what we're trying to provide the evidence for. If we can define that dose exposure response relationship and say to a clinician, you need to target an AUC of 50 microgram hour per mil, find a dose that hits that, then we can say, okay, go to your clinical lab, have them draw a couple samples, get these concentrations out, figure out what the patient's AUC is, and adjust dose accordingly to get to that therapeutic exposure that's both safe and effective.
Joseph, thank you. But can you explain to me what an AUC is?
AUC, area under the concentration time curve, sorry. Yeah, so that's basically the total exposure to the drug over a period of time. So in this case, for ganciclovir, we're usually looking over the entire day, so a 24-hour concentration time curve.
Thank you. That was a great answer.
Great. Well, in the interest of time, I fear we're going to have to move on. Next, we have Joyce Tang with her presentation on vascular malformations in the face, head, and neck. So let's bring up Joyce's video and here.
Hi, my name is Joyce Tang. I'm a professor of dermatology and pediatrics at Stanford University. I'm also the medical director of Vascular Anomaly Clinic, a multidisciplinary clinic at Stanford Children's Health that was established nearly 2 decades ago. The project I'll be presenting today is on treating arteriovenous malformations using MEK inhibitors, a genetically guided approach. AVM is a progressive, life-altering, complex medical disorder, usually present at birth, early childhood, and as being quiescent. However, progression usually occurs 80 to 90% of the time during early childhood, as evident by the overgrowth here demonstrated. As the disease progresses due to rapid blood shunting from the malformation, it leads to tissue ischemia, necrosis, oftentimes associated with pain, life-threatening bleeding, infection, functional impairment, of course, disfigurement, and at end stage, it can be associated with a cardiac failure due to decompensation as well. This is the clinical staging system we oftentimes use to guide our medical management. Currently, in the US, there are over 30,000 individuals affected by this disorder. It truly takes a village to take care of the children with complex AVM. At Stanford, we have physicians from more than 10 disciplines meet every other week to discuss these complex cases. For decades, AVM was thought to be a surgical disorder, therefore managed by these surgical interventions. But surgical interventions always have associated caveats and listed here. Despite all that, recurrence is quite common. For instance, sclerotherapy or embolization alone oftentimes can associate with recurrence as high as 90%. These procedures are also very expensive, and there's no FDA-approved medical treatment currently. The breakthrough about AVM came several years ago when several labs independently identified MEK2K1 mutation and a few others, but this is the most common mutation. What happens with the endothelial cell that line the AVM blood vessel wall is that upon receive a pro-angiogenic signaling, the signals get relayed into the nucleus by these critical proteins. When there's a genetic mutation, the protein structure was altered, specifically MEK inhibitor. Therefore, the signal gets amplified and lead to uncontrolled cell proliferation, disorganized vascular formation, as shown by the nidus here on radio imaging, and it correlates with clinical presentation as well. So intuitively, if we block this signal here, we can reverse the clinical sequelae potentially. So what we're looking for is a MEK inhibitor. Trametinib is currently FDA approved for metastatic melanoma and several other pediatric tumor. Upon the genetic discovery, we thought we can perhaps repurpose this drug for complex AVM patient to shorten the drug development process. This is our proof concept case from 2 years ago, showing that was published in JAMA, showing that 11-year-old with a large AVM over the scapular area that was treated with sirolimus, an specific anti-angiogenic agent. We monitored the patient closely with MR and 3D volumetric analysis. Despite the treatment, the disease progressed. We obtained tissue to confirm the patient indeed has MAP2K1 mutation. The therapy was switched to trametinib, and we saw significant response very rapidly thereafter. Based on several similar observations, we decided that we can move forward with a phase 2 study based on the efficacy and safety data. We know several other institutions, including UCSF, CHOP, and Boston Children's Hospital, are also very excited about the study. Jointly, we developed this 12-month therapeutic protocol and will obtain a baseline imaging, clinical assessment of quality of life, as well as a Q6-month repeat assessment in comparison. This is our overview clinical program from beginning to hopefully more advanced trial stage later. We have completed all these initiation tasks as listed here. In terms of a budget, in addition to the industry sponsorship for free drug, nearly $1 million we have secured. We also received institutional support for personnel, indirect cost, IRB, etc. However, we still need additional funding for data analysis and data storage. And this is where we hope that Care Within Reach will help us to achieve this goal and complete this study. Hopefully that I have convinced you that this is a very important clinical study for AVM children with unmet medical needs. And hopefully in the near future, we'll be able to develop a safe and efficacious treatment for these children to improve their medical outcome and reduce morbidities and surgical complications. I thank the sponsor for allowing me to present our project today.
Thanks, Joyce. You know, I think your project is a really great example of how collaborations among different institutions can really help advance research in rare diseases. So thank you for that. And Bob, since one of the collaborators is in your neck of the woods in Boston, why don't you ask Joyce the first question?
Sure, Dr. Tang, first of all, thank you for a very clear presentation of your project. I wanted to ask you though, you had the diagram that showed how MEK inhibitors work, and there's a pathway that helps the cell growth. And I understand how that can make this arteriovenous malformation happen. But can you explain, when there's already a connection between the artery and the vein, how a medicine can make that physical connection go away?
The medication probably won't make these malformed vessels completely go away. However, it will reduce the signaling, because some of these cells, they do have half-lives. So that if we're able to reduce, kind of slow down the speed of overproliferation of these abnormal cells and allow the normal vascular structure form within the area, it will not lead to downstream additional tissue damage and ischemia and all the other clinical manifestations that we've seen.
Thank you.
So Chris, we haven't heard from you in a little while. Why don't you ask the next question?
Absolutely. Hi, Dr. Tang. Thank you again for a very clear presentation. So yeah, I was just looking for a little clarity on what the primary efficacy endpoint would be for the trial, and exactly how it would be measured, and then if 21 patients being enrolled into the trial would truly be sufficient to establish a proof of concept.
Yes, those are great questions. So first of all, I'll address your question regarding primary endpoint and what exactly we're measuring. So this is what we call confounded or combined primary endpoint. So one very objective endpoint we're going to use for this study is radiological measuring. And as I've shown in our publication, we measure the volume, and we have a special AI software to measure the nidus volume. And we can also measure the speed of the blood flow through the nidus as well. So for these fast flow, they're actually extremely quick. It's 4 meters per millisecond. So it goes through very quick. And so that those changes can be measured objectively, and hopefully that help with the regulatory evaluation assessment of the efficacy of the medication. And then we also take into clinical endpoints into consideration as well, because the patients that we're enrolling have these other symptoms, and such as pain and functional impairment, and those who have a validated questionnaire that we're going to issue to the patients. So we're going to use that as well.
Great, thank you.
Great. And Christian, if you have a quick question, we have time for a quick question.
My quick question would just be, what, if any, patient advocacy groups you're working with, given the broad range of specialties and kind of reach of the issue of this particular malady has?
Yes, that's an excellent question. So we're in very close collaboration with several rare disease groups, and we're also collaborating with the other centers. And so we're all the members of our vascular anomaly clinic center and are members of the national and the international vascular anomaly group as well. And so we do have many interactions with other groups. And I apologize, I forgot to address one of the other points that Chris raised regarding the statistic efficacy. So we did run our plan of the study by our statistician, and so this was the calculation number, and based on our preliminary results, and they give it to us.
Well, thank you so much, Joyce, and the expert panel. Those were excellent questions. And now we're heading on to our final finalist, and our finalist who is from the farthest away. It's a lot of F's. One more, Ignacia Fuentes, joining us to talk about her project in butterfly skin. Let's bring up Ignacia's presentation.
Hi, I'm Ignacia Fuentes. I'm a scientist, and I'm very excited to be here today to present you our project that we think it's gonna change.
Great.
Hi, I'm Ignacia Fuentes. I'm a scientist, and I'm very excited to be here today to present you our project that we think it's gonna change our children's life. I'll have to apologize in advance because some of the pictures I'm about to show you, they're very hard to watch. However, we believe it's important for you to see them to understand the severity of this disease. This disease is called epidermolysis bullosa, or EB, or also known as butterfly children. And to exemplify the severity, I'm going to tell you about a patient of ours. He has a type of EB called recessive dystrophic EB, and because EB starts since birth, he has been living with this disease for 27 years. Besides his many clinical manifestations, he had around 40% of his body covered with wounds, and now he's also suffering from a very severe and aggressive type of skin cancer that is covering most of his back, and it's extremely, extremely painful. We don't want to reach this point. We don't want to reach this point with these patients. We want to go there, treat them earlier as this 6-month-old baby's foot or this 3-year-old little boy's neck. So what is EB? EB is a rare and also considered the most painful disease in children. Around 200 new children are born every year in the United States, but worldwide it's estimated that half a million people live with this disease. Besides being very painful, it's also the life expectancy is reduced. So severe cases can live between months to a few years, or the cases that I showed you before, around 30 years of age. The treatments are mainly palliative care to prevent worse clinical outcome, but as I showed you, that we're by far not there yet. The costs are also very high, and it depends on age, EB type, and country dependent, but in average, a severe case needs around $100,000 a year. All patients have pain, but around 50% of the severe patients have cocoons, hands, and feet, 20% die by sepsis, and 60% because of skin cancer. There are some sophisticated future treatment under development. However, we know they're going to be very costly, and by that, not available to all patients worldwide. So last year, in the middle of the pandemic, we started thinking, what can we do? What's next? What type of treatment we can go to our patients? And we sat down together with our team to think about a simple, easy to implement, and safe treatment to give to our patient. That's how we came up with this compound that is called N-acetylcysteine, or NAC. This is already available in the pharmacy for a very low price, and it's only slightly modified amino acid. This compound by itself, it's an antioxidant, but it also, when it enters the body, it produces the world's most known antioxidant called glutathione. NAC has been approved by the FDA to treat a couple of disorders since many years. And these last years, more and more data has been showing the potential to improve wound healing, and also last year in EB. So the effect will be mainly antioxidant, and that will help with impair inflammation, decrease fibrosis, and endothelial dysfunction, all of which are present in EB wounds. So knowing this, we thought about we're going to have a partially new use for a new disease and a new administration route in this case that is topical. Our trial will be a single-site, open-label, prospective control study, hopefully to start at the end of this year. We're going to recruit 8 RDB patients between the ages of 2 and 18 years old. And although this is a rare disease, our nonprofit also only sees EB patients, and this is only 1/3 of the patients that we see. We're going to follow patients for 28 days, and there are going to be 2 wounds per patient. Wounds have to be larger than 21 days and larger than 10 square centimeters. But for anybody that has ever met an EB patient, they will know this is not a criteria difficult to meet. Half of the wound will be treated with NAC and the other half with placebo. And this is very important because each wound will be a control on themselves. Specifically for EB patient, which wounds move, this is important to have a good control. On top of them, the patient will be used as the primary dressing. The trial will be of 4 weeks, and they will come 5 times to the center to evaluate different parameters for safety and efficacy. But we have also included home visits here in green, in which a nurse from our team will go to the patient's house to ensure that the treatment is applied at every dressing change. Currently, we have the RRB approval is in process, but the team and all the in vitro antioxidant assessment are already in place. The budget for this trial completely is $50,000, and this is unique for a trial like this because of the number of patients and what it involves. However, and it's important for you to know this, that this is only possible because NAC is such a cheap and easy to access compound. Our team is composed by very knowledgeable and experts in the field from Chile and USA, clinicians and scientists. We have been working together for many, many years, and in EB with and for patient, and which is key to ensure the success of this trial. Finally, we believe our trial will have a huge impact on EB patients because there's an urgent need now to get a better, safe, cheap, and easy options to treat these patients. Our study will be a proof of concept trial to generate enough data for off-label use of N-acetylcysteine, or enough data also to generate larger clinical trials. In summary, our trial will reduce wound healing time, either by fibrosis or inflammation or both. And that will certainly translate into decreasing the cost of medical care, decreasing the cost of wound dressings, decreasing pain and possibly itch on patients. But most importantly, it will improve patient quality of life because we need to change the life of our children now. Thank you. Thank you for your attention.
Ignacio, your project is a really important reminder that improving quality of life for both patients and caregivers in rare disease is an endpoint we should all strive for. Amit, we haven't heard from you in a while. You've been too quiet for too long. Would you like to start off the questions?
Sure, absolutely. Dr. Fuentes, thank you so much for this important work that you're doing and the proposal in terms of repurposing NAC and wound treatment in butterfly skin. Clearly, I think you alluded in your presentation that there is no established cure, and it all comes down to kind of palliative care and the management side of these patients with severe pain, inflammation, and a lot of other issues also leading to some of the squamous cell carcinoma. So in your study trial design, you really are picking each wound, 2 wounds for every patient, 8 patients, and then you're really having each of the wound site as both the case and the control. In your placebo component of that, are you really going back to the topical application of the antiseptics, or I didn't really necessarily get on to that? And yes, there is the NAC that you're using on one side, and just because of the proximity of these placebo and kind of the drug, is there any challenges that you have to kind of keep in mind as you kind of go through the trial?
That's an excellent question, and thank you for that. We actually thought about what will be the best alternative for these patients, and as I mentioned in the presentation, their wounds move, so they are very different and they change in size every day. And as a starting point to do the first trial, we believe it's better to do it this way, so that each wound is a control on itself. However, you're right. It is possible that some of the drug will go to the other half, and we're going to try, if possible, to use larger wounds that we don't have that kind of problem. However, we are also going to include to use only the edges of the wound for the application to try to also avoid that point. But that's something that can happen as well. I mean, you're right. But that's not the first time that has been done. This is a technique that has been used in other skin diseases as well, to use the wound as a control.
Thank you. And just the placebo side now, are you using the topical antiseptics there, or are you just kind of...
We're going to use exactly the same formulation that doesn't contain the NAC.
Okay.
On the, yeah.
Thank you.
And Christian, this is a patient-focused project, just like all the others. Let's hear your patient perspective in the last minute we have before it's time to wrap up.
First of all, I'm incredibly proud to see an organization like DEBRA standing shoulder to shoulder with some of the great institutions in the world, and it's just a testament to their international collaborations that they can support projects like these. So thank you so much to the researchers involved. I think my main question, again, is probably going to be in the realm of controls, but not so much in placebo as much as you're relying heavily on kind of patient caregiver tending to this in an 8-week trial. Can you explain a little bit more about the role and the relationship between how the trial will be kind of measured and visited upon by health workers who are coming to the home, and what you would anticipate would be the challenges in kind of controlling the progress there and measuring it?
Yes, I'm sorry if there was a confusion in the presentation. It's not an 8-week trial, it's only 4. It's just a month, 28 days. But that's also a very important point, to be sure that everyone is measured properly, and that's why we are gonna ask patients to come to the center every week, once a week. But in between the dressing change, that's probably 2 to 3 times in the week, depending on how often the patients are changing the dressings. We are gonna send one of our nurses to their house to ensure that the wound the photograph is taken properly, and also that the drug is applied in the right position. And that's something that we think it will not be a problem.
All right, well, thank you again to all of our finalists and to all of our panelists for their work today and their insights. And we will be all making a difficult choice in just a little bit. So now I'm going to turn it back to Barbara to give us some guidelines on voting.
Wonderful. Thank you, Claire. And thank you again to all of our finalists and the expert panelists, and certainly to the attendees. The past hour is another example when every clinical repurposing project that was presented this afternoon deserves to be funded. And Cures Within Reach and our team is doing everything we can to raise the funds to make sure that that happens. If anyone attending today wants to help us and join us in funding all 4 of these amazing projects and researchers, please do reach out to us because we are working behind the scenes starting several months ago in getting some of these projects, all of the projects funded. I do want to make sure to again thank our philanthropic partner, the Charles H. Hood Foundation, who is providing the funding for the winning project, and we're thrilled to have them as a partner this year on pediatric rare diseases. I want to also thank Global Genes and the Orphan Disease Center at the University of Pennsylvania for their partnership and collaboration and allowing Cures Within Reach to bring this event for the 3rd year at the Rare Drug Development Symposium again. So thank you so much to those organizations. As a reminder for all the attendees, as we said about an hour ago, we want all the attendees to consider equally patient impact, speed to patient, probability of success, assessment of the team, as well as the overall presentation and when you make your choice. And the exciting time has begun. Voting, we have now opened the voting. So please go to on a phone or on a laptop or a mobile device, any device of your choosing. You have 1 vote per attendee. It is a short hyperlink, bit.ly/VOTERARE21. It's all lowercase, bit.ly/voterare21. The voting will be open for the next 15-20 minutes until 5:45 or 5:50 Eastern time. 4:45, 4:50 Central Time. Again, vote for either Dr. Gordon, Dr. Rauer, Dr. Tang, or Dr. Fuentes' projects. Please do vote. If anyone has any questions, wants to clarify something, have further conversation, the discussion in chat is open. All attendees need to do is go to the posters on the far left of your screen, select the poster of the finalist you want to have a conversation with, go into the discussion button of view the poster, go into the discussion, and there's an open chat and thread available to everyone there. So we're now going to officially, voting is open, the discussion is open. I want to thank everyone for attending. We will continue to have the slides with reminder information and this link available for the next 15 or 20 minutes. Thanks everyone for all of your votes and for attending CureAccelerator Live for Pediatric Rare Diseases tonight. Tomorrow morning at 10 a.m. Eastern Time, June 11th, we will be announcing the winner at the beginning of the next session of the Rare Drug Development Symposium. Thank you so much again and have a wonderful evening.
Thank you. Good night.
Good morning, everyone. I'm Barbara Goodman, and I'm joined this morning by Claire Thibodeau. We are here to announce the winner of the CureAccelerator Live for Pediatric Rare Disease event, the competition that we held yesterday evening. Before we get to the winner announcement, just a quick information about Cures Within Reach. We are leveraging the speed, safety, and cost effectiveness of medical repurposing research, whether it has philanthropic purposes or commercial uses. As the COVID pandemic has shown to everyone, the fastest way to therapeutic impact and treating patients with unmet medical needs like COVID-19 is through the testing of already approved therapies in randomized controlled trials. As Jim alluded to just a few minutes ago, no one understands this better than the rare diseases community, who has been living in crisis mode from the moment of diagnosis of a rare disease. And we're thrilled that over a decade, we have been funding proof of concept, pivotal studies, first in human studies, to get the data needed for follow-on funding. In fact, our nearly 100 projects that we have funded have invested $6 million in researchers, in clinicians and PIs. And our researchers have follow-on funded. They've raised additional funds for the secondary clinical trial, the phase 2 trial, the larger confirmatory study of $67 million, a leverage and catalytic rate of nearly $10 for every dollar we've invested. Our organization is disease agnostic, we're geography agnostic, we're institution agnostic, and of course we do so much in rare diseases. Over 42% of our ongoing projects today are in the rare disease community. We're here today to select another project in the pediatric space, one of our major 2021 initiatives. Our other initiatives this year are making an impact in veterans, in PTSD and in depression. We're selecting those projects later this summer. And there's an open call for proposals right now. In fact, 3 RFPs in the minority and underserved community, both underserved researchers as well as minority patients and health disparities and in the developing world. But you're not here to hear about us. You're here to hear who won the Pediatric Rare Disease competition. I want to thank the Charles H. Hood Foundation for their partnership with us. We have been partnering with them for under a year. This is our first initiative with them. The Charles H. Hood Foundation was founded in 1942 and is focused on impacting the health and quality of life of children since then. They've been phenomenal partners, very collaborative, and very engaged with the selection of the winner today. I also, of course, want to acknowledge our other industry partners, our philanthropic partners, and other organizations that are so integral to Cures Within Reach and our mission. With that, I'm going to turn it over to Claire, who's going to talk about our finalists.
Thank you, Barbara, and thank you to everybody who attended the event last night and voted. Everybody who attended knows we had 4 fantastic finalists, all of whom had really impactful clinical trials to help rare disease patients and their caregivers. Doctors Gordon, Rauer, Tang, and Fuentes really did an outstanding job. However, this is the part where it comes down to who won the competition. And, you know, at this point, I usually say there is only one winner. But 2021 is a new year, and we are excited and thrilled to announce that we were able to select 2 winners this year. We are just so excited that we will now be supporting the clinical trials presented by Dr. Joyce Tang at Stanford University and Dr. Nancy Gordon from the MD Anderson Cancer Center. So I actually have Dr. Gordon on the phone with us, and I know she'd love to thank everybody who voted for her. Dr. Gordon, congratulations.
Thank you. I just wanted to quickly say a few words. I'm so really grateful for the CureAccelerator, Cure Within Reach, and partner foundations' generosity for their provided support to our patients, who I'm sure will benefit from our investigations. I feel really honored to be one of the recipients. I really look forward to report back to you the results of the study. Thank you very much again.
Thank you, Nancy. We really appreciate you joining us this morning. So again, thanks to everybody who attended, everybody who voted. Your vote does count. And please know that we are very supportive of all the projects that, that presented, and we will continue to fundraise in the hopes of funding all of these fantastic trials. So now I'll turn it back over to Barbara for her closing remarks.
Wonderful. Thank you. And again, congratulations to both Drs. Tang and Dr. Gordon. We're thrilled with that. And as Claire said, we are actively fundraising for the other two finalists.